Hello everyone and welcome to today's Connect and Learn webinar. It's great to have you all with us. Today's topic is brain disease model of addiction and implications for practice. Before we get into today's webinar, I would like to acknowledge the traditional owners of the land where we are presenting from, the Wurundjeri people of the Kulin Nation, and I would like to pay my respect to elders past and present and emerging and any other Aboriginal people watching this presentation. Today's webinar is part of a series of 10 Connect and Learn webinars designed to support alcohol and other drug clinicians throughout regional and metropolitan Victoria. It's hosted by Turning Point and funded by the Department of Health and Human Services in Victoria. My name is Phoebe Spry-Bailey and I'm one of the Education and Training Officers at Turning Point, and I will be facilitating today's webinar. We like our webinars to be as interactive as possible, so please use the functions on your screen to complete polls that will come up within the presentation and ask any questions throughout the webinar, although we will be waiting till the end to respond to any of your questions. If you can, we do encourage you to stay to the end of the webinar and where you'll be directed to complete an exit survey. And on this survey, there's also opportunity for you to suggest topics for future webinars, which is really helpful for us in our planning, particularly for next year. Before I hand over to our presenter for today, I did want to introduce him. So our presenter for today is Tony Barnett, and he joined Turning Point in 2018 as a research officer. He's been working in the clinical research team. His work explores the views of consumers and clinicians about different forms of drug and alcohol treatment, care and recovery across a range of different settings. Tony's PhD research at Monash University has focused on Australian drug and alcohol treatment providers' views about the brain disease model of addiction and how neuroscientific models integrate with practice. And this is what he'll be talking about today. He specialises in qualitative and mixed methods research. His primary research interests lie at the nexus of psychology, health, sociology and neuroethics. Furthermore, his work aims to inform improved healthcare delivery in drug and alcohol settings, along with policy development both locally and internationally. So welcome, Tony, to today, and we look forward to hearing what you have to say.
Brilliant. Well, thanks very much for that intro, Phoebe. And it's great to be discussing the brain disease model today and its implications for practice. You want to get back with any feedback, or you don't have a chance to ask any questions at the end of today's talk. So it's been a really topical issue. This is a really contested space that we're operating in. It's also been front and centre of everyday discourse. So I've just taken a few screenshots there. You might be familiar with books by Gabor Mate, TED Talks by Johann Hari, or a few years ago, Professor Mark Lewis, the Canadian neuroscientist, visited Australia, where he talked about his book, The Biology of Desire, and Why Addiction is Not a Disease. So it has a really long history. And that history is something that I'll get to later, so this is just the contents. Also be looking at some of the contemporary research that I've been involved in about treatment providers' views about the brain disease model. And finally, we'll be looking at some implications for policy and practice. So before we go on, and we'll do two polls today, but it's the same question, so it's essentially we're very scientific here. It's a pre-poll and a post-poll, and there are three things you can select: either disagree, neither agree nor disagree, or agree. And I thought I'd put this statement out. Alcohol and other drug addiction is a chronic relapsing brain disease. So we're jumping right in the deep end, you might say. Just looking down here as people answer that question. So it'll be interesting to, I guess, a litmus test for the audience's opinion about this topic. And like I said, we'll do one at the end of the talk. Okay. Right, so we'll just give that a few more seconds. Interesting. I've also got some survey results that I'll be discussing a bit later on, so it'll be interesting to actually compare those to what we're seeing now. So just maybe 5 more seconds. All right, well, before we move on, what have we got? We've got about 20% saying they disagree, about a third, or 37%, in the middle, and about 45% saying they agree. So it'll be interesting to compare that to the second poll we do. So the first part, let's look at the brief history. So like I said, this topic has a really, really long history. The early formulation, you might say, of the disease concept can indeed be traced back a long time ago to Dr. Benjamin Rush, one of the forefounders of the US, all the way back in the late 18th and early 19th century. So I guess around this time there really was a growing preoccupation with drunkenness or alcoholism constituting a threat to, I guess, organised society. It was a period around the time of industrialisation. So that meant that society needed a reliable workforce, and public drunkenness, as is very aptly and vividly represented in Hogarth's Gin Lane on this slide, public drunkenness was increasingly a threat to social stability. So Rush's early disease model of alcoholism, it really saw an important shift where alcoholism was now viewed as an individual pathology, you might say, or a disease of the will, as Benjamin Rush put it. So I guess rather than being a moral problem, or rather than merely being a sin or a character flaw, addiction was now constructed as a disease, which meant that it now came under the purview of medicine. Now this really is a whirlwind history, so if there's any history buffs out there, I do apologise in advance. But if we roll forward in time to the 20th century, and I guess this is post-repeal of prohibition in the US, the rediscovery, as many historians have called it, so the rediscovery of the disease concept was really attributed to a confluence of social and political factors. And just on this slide, some of those factors, there were three main factors. That was firstly the birth of the AA and NA movement, or what we might call 12-step programs. Also the Yale Centre for Alcohol Studies, which was a research centre in the States that was doing a lot of research on the topic at the time. And of course, Jelinek's text, The Disease Concept of Alcoholism. Now if we go forward further in the 20th century, and this is really as neuroscience took off, so with advances in neuroimaging technologies in the 1980s, this process of medicalisation that I've talked about really coalesced into a process of biomedicalisation. So rather than just being a disease of the body, the brain was now the central focus for scientists. Indeed, it was a brain disease, it was at least characterised in the US as a brain disease, if you like. Now, just on that slide, so in 1997, Alan Leshner, the then head of the National Institute on Drug Abuse, which still controls the vast majority of global funding focusing on addiction neuroscience, he put out a paper saying addiction is a chronic relapsing brain disease and that matters, and that is sometimes viewed as heralding the real commencement of intense support for the brain disease model of addiction. The model's been front and centre and still is, especially within US national drug control policy. So I've just got that example there from the US National Drug Control Strategy from 2014, signed off by President Obama. I think the first sentence in that document makes the claim that decades of research have demonstrated addiction as a disease of the brain. Now, interestingly enough, if we look at Australian National Drug Control Strategy documents, we don't necessarily see such explicit support for the brain disease model of addiction. Having said that though, and more recently, I did note that the Australian Medical Association, so I think this is from 2017, they have, I guess, followed on from a public policy position statement made by the American Society of Addiction Medicine, framing addiction as a brain disease by making the statement addiction is a primary chronic disease of brain reward, motivation, memory and related circuitry. So I guess this brings us to today where, it's a really contested space. We have both advocates and those that are heavily critical of the brain disease paradigm, and I just wanted to discuss some of the key points from those debates. So there have been a number of proposed benefits of viewing addiction as a brain disease. For example, that more effective treatments might emerge from the brain disease model. more effective treatments might include pharmacotherapies that are more effective with less side effects. Viewing addiction as a brain disease, it is argued at least, might also lead to what is often viewed as a moral problem being accepted as a real disorder. Furthermore, it might reduce the stigma attached to addiction. And finally, it's argued that the paradigm in general might attract greater investment in research and treatment. However, there's also been a lot of criticism of the brain disease model. Critics have said that, look, the model's overly reductionist insofar that it ignores a whole range of other factors that might be implicated in addiction, for example, psychological factors, social factors, or environmental factors. Secondly, and this is probably the main thing that's still playing out at the moment, is that neuroscientists themselves are still debating whether or not the neuroscientific evidence actually supports a brain disease model of addiction. For example, and this is especially the argument that Mark Lewis has led, and you can read his book for more details about this, but he's said, and he's got a lot of support from colleagues in neuroscience, he said that when you look at the neuroscientific evidence, maybe it better suggests that rather than characterising addiction as a brain disease, addiction might be a problem of deep learning, as he puts it, or he classes it perhaps as a neurodevelopmental disorder. In addition, some of the epidemiological evidence has also cast doubt over this brain disease view. For example, epidemiologists have said when they look at data across the whole population, a lot of people who might have been diagnosed with substance use disorders do stop using drugs or cut down their drug use in their 30s or 40s, what is sometimes known as the maturing out hypothesis. So if we see that data, does that necessarily support a brain disease view of addiction? That's one of the big question marks. Finally, it's been said that viewing addiction as a disease, it tends to overly focus on medical interventions at the expense of, say, public health interventions or interventions that look at legislative change or taxes. So, what I've really noticed is that those debates that I've just given you a taste of, if you like, they're often dominated by academics. They're not really grounded in experience of frontline clinicians, and that's what I'm really interested in. So, what are treatment providers' views about whether or not addiction is a disease or brain disease, and furthermore, how do they view the potential clinical impact of the disease model? Now, and I think this is largely self-evident, but their views are important. So if they've often been ignored, I mean, what does it mean? I mean, their views are important because it really gives us insight into how consumers might experience treatment based on treatment providers' views around this topic. And furthermore, and critically at the moment, it'll aid in policy development. I guess one of the criticisms generally of drug and alcohol policy is that, largely speaking, it's been a top-down process where the bottom-up voice of grassroots clinicians that really work at the coalface of treatment, their views haven't necessarily been integrated as best as they could within evidence-based policy. So their views are important on this topic. And moving on to this second part of the talk, that's indeed what I'll be discussing. So treatment providers' views about the disease model. And I'll be looking at 3 studies that I've been involved in. The first study is a systematic review of previous research on the topic. The second study is a large international survey that we've recently conducted. And finally, we'll be looking at some qualitative research about how treatment providers discuss the brain in clinical practice. So, moving on to study number 1. So this was a literature review that we conducted. And the key research questions that we were interested in were twofold. Firstly, do treatment providers support the disease and brain disease model of addiction? And secondly, what are their views about the potential clinical impact of framing addiction as a brain disease? So there are 3 levels of key findings in this first key finding about treatment providers' support for the disease model. So like I said, we were trying to be robust in our analysis here. So we wanted to find every empirical study that had looked at providers' views around this topic, and we actually found 34. So there's actually been quite a lot of research, and that was conducted all the way back from 1969 through to 2015. But of those 34 studies, 26 were quantitative, and a lot of them, you might say, a lot of those studies were utilising, say, non-validated instruments and weren't necessarily that high quality. We did find 8 high quality studies, and from those best evidence studies, if you like, what we really found is that it's not a simple matter of saying treatment providers, it's not a binary issue, if you like, as far as treatment providers either support or don't support viewing addiction as a disease. Rather, what we found that it's much more complex. So we found that treatment providers commonly held what you might call amalgamated disease model support, insofar as they might simultaneously support different models. So for example, I've just used this example here, so a number of studies suggested that providers might simultaneously support, say, a disease model, but also free will model. Now, you might ask, well, that seems contradictory. How can you support 2 models that might seem contradictory or might seem inconsistent with each other? And just down the bottom of that slide, I've given an example. So if treatment providers thought that to overcome their addiction, people had to... So firstly, some providers thought, well, people will have to, A, rely on their own willpower, and that might be considered part of a free will model of addiction. But also, simultaneously, providers might think, well, people need to seek treatment as a solution, which might be part of, viewed as part of a disease model. So this leads to this finding of support for hybrid models. So one of the reasons why that might be is that in certain clinical, and this is just what we, I guess, argued in our analysis, but it does require further research. But what we thought was that treatment providers might strategically deploy the disease model in certain circumstances, say to de-responsibilise someone for their AOD use. But say, for example, with another client, or even with the same client but at a different stage in what you might call a recovery journey or within their treatment, disease models or aspect of a disease model or brain disease model might be deployed at different times. In regards to this second key finding, so what we wanted to do was, I guess this speaks to across AOD workforces, we wanted to see whether there was any individual demographic factors for treatment providers that were associated with disease model support. And we found some interesting things, for example, being older, so treatment providers who were older, generally speaking, when we synthesised the findings across the whole corpus of literature that we analysed, we found that treatment providers who were older were more likely to view addiction as a disease. One of the reasons for that might be is that, say for example, people that did their training in the 60s, 70s or 80s in the States, support for the disease model and brain disease model might have been more integrated in education models back then compared to now. So hence that plays out that support for the disease model still plays out in their thinking about AOD problems. Secondly, and this is probably the most, I guess you might call, salient predictor, treatment providers who themselves might have had AOD problems or describe themselves as having a previous addiction, people that have a previous addiction, and especially those who had attended 12-step programs themselves, that was associated with high support for the disease model and brain disease model. And that might be, say, for example, when treatment providers have, I guess, worked the 12 steps, you might say themselves, some of the disease model ethos within 12-step programs might have, I guess, imparted on their practice. Thirdly, and this is something that I'll be discussing soon in the survey results that I present, treatment providers in the US were more likely to hold a medicalised view of addiction, and that I'll reflect on that at the end of the talk, but one of the reasons for that might be some of the history that I spoke about at the start of the talk. Just on the other side of this slide, greater levels of education were negatively associated with disease model support. And one of the reasons for that might be is, let's say, as people maybe do an undergraduate degree and then postgraduate qualifications, as they do higher levels of education, they might be exposed to different models, hence support for the disease model lowers or is less, it's less central to their practice. Now, this final finding, well, what did treatment providers think about the potential clinical impact for a client if a client viewed there a problem in terms of a brain disease? Firstly, it was thought that for that client, potential other factors involved in the etiology of addiction, for example, social or environmental factors, might not be considered appropriately. But these next 2 points are really important and something that I'll again talk about with the survey. It was thought that there could be potential positive clinical impacts for some clients. For example, it was thought that for some clients, if they viewed their addiction in terms of brain disease, it might lead to increased treatment-seeking behaviour. And that might play out insofar as, let's say, for example, someone saying, oh, look, now I know that I've got this medical problem, I can go and get treated. Another potential positive impact was reduced guilt. The old adage, it's not me, it's my brain as such. On the other side of the coin, it was thought that for clients who viewed their addiction in terms of brain disease, it might also be negative. And just a couple of examples there. Firstly, it could be stigmatising, so someone thinks of their damaged brain, maybe that they're out of control or dangerous or should be avoided, that sort of the stigma that's attached to, for an already stigmatised population, you might say, but an increased stigma. And also, for other clients, it was thought that it might reduce their sense of responsibility, or perhaps a better term there is self-efficacy. So if people have a reduced sense of self-efficacy, it might lead to what cognitive psychologists describe as being in a state of learned helplessness and reducing people's attempts at recovery. It was also thought that, generally speaking, if practice was informed by a brain disease model of addiction, it might favour certain treatments. And the main example I've given there is that it really might lead to people thinking about abstinence as the only recovery goal, rather than thinking that harm reduction interventions might be appropriate. And I think one of the reasons for that might be that in that history that I gave at the start, along the whole sort of lineage of history, disease models have often been associated with abstinence and temperance movements and so forth. So that's the first study. Now, in this second study, so we conducted an international survey of treatment providers' views about the topic, and I've just listed the research questions there. So I should say it was an international comparative survey of treatment providers in the US, UK and Australia, and we wanted to look at their support for, and we included another model, so we looked at their support for the psychosocial disease and brain disease model of addiction. And we also wanted to survey their views around the clinical impact of the model. So, to the best of my knowledge, this is the largest survey that's been conducted in these 3 countries. And we've had about 1,400 participants in the survey, approximately 900 in America, 170 in the UK and 330 in Australia. So if anyone watching actually did that survey, a big thank you. Now, I've got 3 slides here, and I should say we asked a whole range of different questions. Some were about harm reduction, some were about neuroscience, some were about disease. I'm only giving a very limited sort of view of the results here, but I thought I'd just sort of, I guess, cherry pick some interesting stuff for today. So, with this first graph, we used the short understanding of substance abuse scale, which tested people's support for both the psychosocial and disease model of addiction. Now, so if we look along the horizontal axis, we've got the 2 models. So it's interesting to see there that in terms of psychosocial model support, there wasn't a significant difference between treatment provider support for the model between Australia, the UK and USA. But when we moved on to the disease model, interestingly enough, you can see that blue bar there. It was lowest across the 3 in Australia, then middle it was the UK, and treatment providers in the US sample were more positive in their view towards the disease model. So that was about the psychosocial and disease model. Now, in terms of brain disease model and measuring views around that, there are no psychometrically validated instruments for the brain disease model. So what we did was I created a few what you might call ad hoc statements. So this first one was, and this is very similar wording to what we actually did in terms of the poll we just conducted. So we put forward the statement, addiction is a chronic relapsing brain disease. And along the vertical goes from strongly disagree up to strongly agree. And interestingly enough, again, we didn't see a huge difference between the sample in Australia and the UK, but the treatment provider sample in the US had a significantly higher level of support or level of agreement with that statement. And I'll come back at the end to reflect on why that might be. Now, hopefully you can see this. This graph's a little bit busy, but this final statement that we put forward in the survey was, if addiction is talked about as a brain disease with clients, it. And then what we did was, and you can see this along the horizontal axis of that graph, we put forward to people 6 possible clinical impacts. The first 3, I guess, are more positive. So if addiction is talked about as a brain disease with clients, it. So we had reduces guilt, increases insight, and increases treatment seeking. And then the next 3 potential clinical impacts were, I guess, in the negative. So it was increases stigma, reduces personal responsibility, and increases helplessness. So we got these from the systematic review, and we wanted to really, I guess, probe about using quantitative methods, levels of agreement with these particular potential clinical impacts. Now again, when we look at the blue and red bars, the samples in Australia and the UK, they didn't differ that much in views around levels of agreement with that statement. However, when we look at the US sample, in relation to the first 3, so reduces guilt, increases insight, and increases treatment seeking, the US sample was more strongly in agreement with that. And furthermore, with the next 3, increases stigma, reduces personal responsibility, and increases helplessness, the US sample was less likely to agree with those that talking about as a brain disease with clients would lead to that. So in sum, what we might say is that treatment providers in the US sample were more likely to view the brain disease model favourably in terms of its clinical impact, and less likely to view its less likely to view it unfavourably, you might say. And I know that's a double negative, but I hope you understand what I mean. I should say that there's a couple of limitations. Secondly, this stuff hasn't been peer reviewed. It will be shortly, and hopefully the results will be out soon. And yeah, finally, it is difficult to make cross-country comparisons due to the non-representative sample. But at the end, I'll be talking about what the results might mean. But yeah, there are a couple of limitations there. So we've covered the first study, which was the systematic review, the second study as well, which was the international survey. In this third study, so this was some qualitative research exploring treatment providers' use of neuroscience. And the research question here was, how and why do Australian treatment providers discuss the brain in clinical practice? So we really wanted to probe using in-depth qualitative methods around treatment providers' use of neuroscience in practice. So we conducted interviews with 20 treatment providers, and the interviews were all conducted here in Victoria in the public AOD sector. Now, a whole different range of professions, ranging from addiction medicine and psychiatry through to nursing, psychology, counselling and social work. Some of the participants freely identified themselves as having past AOD problems, and they discussed that in terms of disease and maybe AA experience. So that was interesting, especially what I talked about in terms of the systematic review, with people having different views, sometimes employing personal knowledge, sometimes employing what you might call technical or professional knowledge about the topic. And we wanted to we went to 5 different sites to conduct the recruitment. So that ranged from a therapeutic community that was a short-term abstinence-based model, everything from that through to inner and outer interdisciplinary harm reduction-based clinics in Melbourne, and also a psychologist in private practice. So the interviews went for about an hour. There was a lot of themes that were covered, and I thought I'd present just a couple of those themes today. But if you'd like more info, there's a couple of papers. There's one that's been published and another one that's coming out soon, so I can always send you that if you get in contact. Now, with this first theme, we really found that treatment providers were highly selective and strategic in the way they discussed neuroscience. And it was rarely in terms of the term brain disease. And some of you might agree with that from your own experience, and this has generally been my experience. It's quite rare in Australia to hear treatment providers using the explicit term brain disease. Having said that, neuroscience is discussed in other ways and highly selectively. So I just thought I'd give an example quote there. So I asked the question to everyone with clients, do you ever discuss the brain? And here I've just given one example from an interviewee. This was an addiction psychiatrist. They said, yes, rarely, so not 100%. I usually pick the client who, first of all, might express an interest in it, then I always would. So I guess what I'm saying is I tend to discuss it only when I think it's helpful for whatever reason. It isn't always kind of an essential part of how I discuss diagnoses. So really the take-home message there was the brain was only discussed when it was perceived to be, I guess, what you might call therapeutically beneficial. In this second theme, we found that neuroscience was often discussed to maintain optimism or for therapeutic gain, so in positive terms. So discussing things, I guess, explicitly in terms of a brain disease was viewed as negative and not really leaving much space to work with a client therapeutically, but rather neuroscience was often discussed in terms of, or in an attempt to maintain optimism. And one of the examples I've given here is people discussing neuroplasticity. Now I've got two quotes there. Just for time's sake, I won't read out the counsellor's quote, but just with this next data from the study we conducted, here we had an addiction medicine specialist, and they said, when I asked about neuroplasticity and whether they discussed it, they said, yes, definitely, because the brain changes, the brain evolves, your ability to self-manage stress, anxiety, depression changes. Then they go on to say, that's the neuroplasticity that you were talking about. It's absolutely critical for all the maintenance of optimism, and I think maintenance of optimism is a key part of our therapy. So we can see that's a really good example of someone, I guess, deploying neuroscience in a highly selective manner, but for a strategic sort of therapeutic gain, and not always in terms, or rarely, I would say, in terms of a brain disease. So this brings us to the end of the results, and what I'll do after this poll is just discuss some of the implications for policy and practice. But yeah, it'd be interesting to see, I guess this is the post-intervention poll, if you want to call it that, or post-presentation poll. So it's the same statement. So if everyone wants to just select A, B or C, disagree, sitting on the fence, we'll call it, or agree in answer to that statement, we'll just monitor that for a few seconds. Okay, so we'll just, there we go. Excellent. All right. Okay, well, that's really interesting. So 30% disagree. Oh, we're changing. Yep. Okay, I'll be quick. 35% disagree, or a third. It's actually about the whole, samples has gone a third each way. So a third disagree, a third in the middle, and a third agree. So make of that what you will. Off the top of my memory, it looks like that the presenting the results have kind of led people towards answer A or B in some ways, but we'll leave that up to the statisticians. So finally, what does this all mean for policy and practice? And there's a lot we could discuss here. Get in contact if you want a copy of especially the systematic review where we unpack this further. But what I'd talk about is three things. So firstly, what does it mean for policy? So I think it's really important that we remain cautious about the effects of integrating the brain disease model within Australian drug and alcohol policy. Based on the results of and some of the research that I've just discussed, there is a growing body of evidence to suggest that the disease and brain disease model may be viewed more favourably in the US, by treatment providers at least, in comparison to their UK and Australian colleagues. So I think we need to be very cautious and need to be very, reflexive about the, perhaps you might say, potential unforeseen consequences of transplanting a model that's appears quite popular in US drug policy directly into Australian drug policy. We need to remain cautious about that. What does it mean for practice? So I've divided this up into two sections. The first section is, well, and this is something that you all might be thinking of as I've been talking, is it helpful for clients to understand their AOD problem as a brain disease? So again, reflecting on the research that I've just discussed, as we've seen, treatment providers that we interviewed really thought that it might have a potential positive impact for certain clients, for example, increased treatment seeking, better engagement, and reduced guilt. But for others, it might have a negative impact, increased stigma, reduced sense of self-efficacy and attempts at recovery. So I think what we can say is it's really up to treatment providers in general to exercise their own clinical judgment about whether the disease concept is going to be efficacious for a particular client. Now, for some clients, they might come into care viewing their addiction as a disease, and that might work well for some people. For example, some clients, AA or NA or 12-step in general, might really have been successful for them in working the 12 steps and thinking about their AOD use in terms of, or through an AA lens, if you like. So, whereas on the other side of the coin, for clients who view their disease, AOD problems as a disease and might have attended 12-step, it might be negative. So again, that's all about clinical judgment and seeing how it works best for a particular client. This final slide, and again, this is about practice. So I was thinking, what effect might the brain disease model have for practice? So I guess it's really important to remain aware of how framing addiction as a disease of the brain might, bring certain concerns to the foreground while also relegating other concerns or considerations to the background. So really, when we think about addiction in terms of a brain disease, it really isolates the drug problem inside the individual. So in doing so, it might necessarily relegate other concerns, and here I'll give an example of psychosocial concerns. Might relegate those to the background. So a quick example, if you think about a client who might have really acute and pressing psychosocial concerns, say housing issues or homelessness, we might very much doubt that the thinking about addiction in terms of neurobiology is relevant, but also that model might really look at the problem as an individual problem where it needs to be viewed more holistically. And I'll just leave you with this thought. I guess this really sort of hammers home that we all need to remain reflexive about how models, and whether it be the brain disease model or another model, for example, the biopsychosocial model, we need to remain reflexive about how different models impact practice. So what factors do different models foreground? How do they align with clients' understanding of their own AOD concerns? And how might models impact care? So that's really, it's important to remain reflexive, to discuss with colleagues about the social effects of different models that inform treatment and care. So before we get to the Q&A, I just thought I'd list a few acknowledgements. Firstly, thanks very much to the treatment providers who participated in this research and collaborators, and especially thank you Phoebe and the workforce development team at Turning Point for the opportunity to talk today. Thanks.
Thanks, Tony. You did amazingly well in summarising all your research and talking about implications for practice into a really short period of time. So thanks. It's so interesting. And I was thinking as I was listening and you were talking about some of your qualitative research that you did, and I thought, another idea we could have had for a poll question is, and it might be something, if listeners might want to think about, and be interesting to hear if people actually do discuss the brain with their client, that they're working with. But I guess it's a bit hard to do that in a webinar. We have got some questions. So our first question is asking. It says, "Hi, you speak about addiction. A small percentage of drug use is addiction. Is there a differentiation between social or normal drug use, problematic drug use, dependent drug use, and addiction? Who needs treating, and at what point is a so-called disease?
All right. Well, that's a good question to get started. And the first thing I'll say, and reading the question, one thing that I perhaps didn't say when I was talking is even the notion of addiction. I think that's picked up in the question here. Even the notion of addiction is considered problematic. A lot of places where I've conducted research, and in my own experience at Turning Point, a lot of clinicians indeed don't use the term addiction. Firstly, it's stigmatising. And secondly, it sort of isn't perhaps that useful in clinical practice. For example, is it so simple that one person isn't addicted, the other person is addicted? What I find, generally speaking, in clinical practice is that problems or concerns are viewed on a whole continuum. So in answer to your question of, as soon as we use the word normal drug use, we're getting into some very contested sociological ground. But in answer to, or just to respond to the question, I think we need to really remain reflexive about this notion of addiction. Disease is another one. It's a highly loaded term, and it is difficult sometimes to define. But to respond to the question, I think that less stigmatising language in care is probably better, and also really using terminology and using models that remain sensitive and remain aware of the very complexity and broad array of AOD and psychosocial concerns that people present with. So hopefully that's a response that will answer that.
Thanks, Tony. We have got a little bit of time, so now's your chance. If you want to ask any questions, please do so. We just have another question that's here. So you focused on the US, UK and Australia during your presentation. Has there been research about the disease model in other countries? And are there any did you notice any cross-cultural differences?
Right. Okay. Wow, these are good questions. So I guess I've taken a very US-centric historical view when I started with a brief history. And even in the US, we've noticed that over time, over decades and centuries, the notion of addiction, exactly what it is and how society responds to it, waxes and wanes over time, comes into points in history where it's more medicalised, if you like, other points in history where it's demedicalised, and that's only within the US. So when we look across the globe, it's even more complicated. There are other, I guess, jurisdictions where, and I really come to think of it, a really good example is actually the Nordic region and Scandinavian region. So if you look at Finland and Sweden, there's very much a very long tradition of viewing AOD problems in terms of societal problems or having social underpinnings and social causes. So I guess in answer to that question, I've given a very US-centric whirlwind history. We can never assume that addiction, I'll use that word again, that drug use or addiction is viewed in similar ways both across time or between and within other societies. So it's really complex. There's been some really good history books. Virginia Berridge's comes to mind, also the work of Robin Room about how the notion of addiction has waxed and waned over time. But yeah, if you want any more information, I can always supply a reading list. So.
Thanks, Tony. And there is just one more question which I will ask. So this person says, hi, thanks for the fascinating talk, which I totally agree with. I've been thinking about the role of disease models in policy. I suppose a complementary question to your research, but I wondered if you could tell us whether you think the disease model would be useful or otherwise in policy.
Okay, that's a really good question, actually. So I wondered if you could tell us whether you think the disease model would be useful or otherwise in policy. So, well, again, as I said, when I did the final section on implications for policy, I think we need to be really careful about how we look at and consider the effects of disease or brain disease model stuff and how it informs policy. In the US, I guess viewing addiction as a brain disease in policy, that actually has some historical roots, because what that does politically is it really isolates the problem of drug use and the problem of addiction inside individuals. So I guess critics might say that what that does, or one of the things that does, is that it de-responsibilises government to look at more complex solutions to the problem, because they can just say, well, look, this is a disease that's inside the individual. We don't have to, say, pull legislative or tax levers, which might be more complicated. We can just invest in treatment. So whether or not the disease model would be useful in policy, there's a number of effects of that, like I just said, that it targets the individual perhaps. Maybe elements of viewing addiction as a disease might be useful in policy, whereas other elements and very much some unforeseen consequences can also play out. So I think especially in terms of Australian AOD policy, we really need to remain very cautious about viewing addiction as a disease. It might be essential, what you might say is essentialist, that it really narrows the scope of drug and alcohol policy interventions and doesn't take into account wider public health interventions that are really important in addressing addiction concerns. So remain cautious about putting the disease model in policy is the take-home message.
Thank you. Ooh.
Yeah.
We've got time for one more question.
Yeah, okay, we'll take one more.
Yep. And we can always follow up, because there are a few sitting here, so we can follow up with these individually too. So, where are we up to? So here's a question. Are there any studies comparing rates of relapse and recovery compared to the model of addiction being used predominantly in that country?
Okay, right. This might be the one that stumps me, but we'll have a look. So, all right, so are there any studies comparing rates of relapse and recovery compared to the model of addiction being used predominantly in that country? Right, that is a really good question. Yeah, okay. Then I think that there definitely needs to be more research in that. That is really complex to research. So we might sort of, I guess, reframe that question in asking, has there been empirical research to see whether or not drug policies at the societal level have good effects on recovery or reduced drug use? I mean, what can you say? The US again comes to mind. I mean, a brain disease view has been front and centre of US drug policy of late, and I guess at a grassroots level, there's also been the emergence of the opioid crisis. So I'm not for one moment attempting to say that US drug policy has caused that, but what I am saying is that it would be really interesting if there could be more research to see how high-level drug strategy influences these types of problems that the US and other countries are now dealing with. So I think if I had the answer to that question, you could theoretically implement evidence-based policy that was going to be positive. But no, it requires further research. So I know that's probably not the best answer, but that's the best I can give.
Thanks, Tony. Okay, we're going to leave the questions there. So final thanks to Tony for taking the time of your day out of your day and coming along and presenting in our Connect and Learn series. And thank you to all the viewers out there for watching our presentation and asking all these fascinating questions. And I do apologise, we can't get through them all today. The other thing I want to tell you about is our next webinar, which is on Thursday the 29th of August at 1 p.m. It's Naloxone Saving Lives. It's presented by Chris O'Mahony from Pennington Institute. Registration is available on the Turning Point website at the moment, and for those, and will be advertised via VADA e-News in the next, hopefully by the end of the week, I think. And so, yeah, if you could stay on the line, because Redback are going to put out a survey for you all, and and again, I'll say this again, we really appreciate your feedback in relation to future webinars, so we can make them as relevant and practical for you in all the valuable work that you do as AOD clinicians too. So thank you so much for stepping in today for the past 50 minutes, and we look forward to seeing you next time. Thanks.